Okay, so yeah, I hope all of you guys can see this. So inshallah, in this next hour, we will be learning how to manage migraine, the journey to headache freedom. It is, yeah, I'd like everyone to keep their mics muted. Otherwise, I might have to just, force that. Yeah, so, yeah, okay. Okay, so again, the next hour is going to be about migraine. Inshallah, it will answer a lot of your questions and it will answer a lot of the concerns that people might be having regarding this disease. So it's a little bit about me. I'm Dr. Gohar. I am a neurologist and I am actually foremost a student of neurology. And I'm sure you guys are students of neurology as well. And this is a lifetime of learning. I'll be learning while delivering this lecture. And I hope you guys, some of you, learn some things as well. So this is my alma mater. I really love this place. I completed my MBBS and my postgrad from this particular place. So we'll be talking about migraine. The first question is, what is migraine? Many a time we think of migraine, and in popular culture and the society, we think it is a half-headed headache. Yani aadhe sar ka dard, but that is not always true. Migraine is something that is a headache with a lot of other associated symptoms. It is a disease, it is a complex of things that happens together. And very important to know that there are many phases of migraine, and in between headaches as well, the people who have migraine have some issues. And thus, if someone is having migraine, it is not just the headaches that they have during the month. They can be half-headed, full-headed. We'll come to that later. So we divide migraine into premonitory, aura, headache, postdrome, interictal. We'll come to this a little bit later on. Now it is widely accepted that migraine is a disorder of sensory processing, and it is widely regarded that it is inherited, and it involves many genes, some of which are being discovered, some of which will be discovered a little bit later. But basically, the sensory processing is at fault here. It used to be that people used to think it is due to the vasoconstriction and vasodilation of blood vessels in the brain that caused migraine. But that theory is not supported now by the available evidence. New receptors, CGRP receptors, and the involvement of the trigeminal system in the pathogenesis of migraine basically led to our further understanding that it is far more complex, and more mechanisms are being discovered in addition to these mechanisms. So we'll be learning more about migraine as the years go on. So a lot of work has been done in the past few years. This form of headache medicine and migraine medicine has seen a revolution, and lots of new therapies and lots of new things. We'd go through them. So this is a good description of migraine. And you see the pills on the right hand, and you see something being struck into the head. So yeah, migraines make you cry. They're pretty bad. So basically, how to describe migraine is basically something that is a headache disorder, but it involves the entire body into it. It is the second most common cause of primary headache worldwide. How do the patients present to you? They present obviously with headache. The most common cause of headache worldwide is tension type headache. However, they don't come to your clinic. They don't come to medical specialists or neurologists or neurosurgeons or whoever they present to. Migraines are the headaches that come to your offices and come to your presentation, because it is a leading cause of disability. It is a severe headache, and it can be seen as the most disabling disease in the world. In Pakistan, around 23% patients, people have migraines. It is 3 times more common in younger age groups. We'll consider it in young people, and more so in females as compared to men. Just see, around 40% of the females in Pakistan are affected. Remember that Mavish Hayat commercial Sardar. Well, there was a reason they chose a female for that, and it's not because of some other reason. It's because they unfortunately have this predisposition of having more migraine headaches than men. It is really important to know it is treatable and it is preventable. Basically, to understand what a migraine does, we need to understand the types of migraine as well. Basically, there are 2 types of migraine. Aura basically means the signs and symptoms, mostly symptoms that the patient suffers before the headache starts. These aura symptoms usually last between 5 to 60 minutes and take place before the headache happens. So we are well aware of some aura symptoms, which include visual blurring, seeing fortification spectra like we see around here, seeing rainbows, and other people can have sensations, paresthesias in various parts of the body, sometimes weakness of one part, stuttering, and loss of vision as well. But it is very important to remember that migraine with aura is far less common than migraine without aura. So it's around 2 by 3 patients coming without aura and 1 by 3 patient coming with aura. So basically, it's a 5 to 60 minutes transient occurrence of signs and symptoms that basically ends before
Mike,
the
before we
headache.
go,
So this
can you
is a
get that
good
screen
example
over
of
hardware,
somebody who has
handsome
an aura,
things? Like,
and
no,
Mayo
we've got to
Clinic made
trim the
this
hedge, or it's going to look
wonderful
really
video. You
horrible by
see
the time we get
that the
back.
headache is about to
I'm trying to think
start,
what else.
and
Oh
there
yeah,
is an
yeah. Can you bring
aura
all the
that
storm
starts
windows down
appearing
on the
around
bottom
here,
floor so that
and
they can,
he the
you
person
look, you know, well, you
we
do
are seeing in the
say,
first person mode.
Mike,
The other
are
people
you
understand
listening
that
to
there's
me?
something that is about to go on
You look
in
dazed.
this person. So these can be strange symptoms, including um, some tinnitus, some hearing loss, mood swings associated with it. It can be vertigo, and there are some strange symptoms associated with the headache as well. So basically, many a time when these strange symptoms come into the clinic, we take the history of headache, including take the history of migraine, and we deal more with that in the coming slides, and they find to be quite related. And when you control the headache, then the symptoms go away. These are the basic few types of migraines. When you go into details, acephalic migraine is a migraine in which only the aura happens and the headache does not happen. Other symptoms of migraine happen. Basilar migraine, migraine with brainstem aura, it's now called. It is happening when brainstem symptoms, including slurred speech or scanning speech or weakness or sensations, loss of sensation occurs before the migraine and even during migraine as well. Some childhood periodic spells, including children who vomit a lot, or sometimes with children with torticollis or dystonia, you find out that they are actually having migraine. So many a time children complain of abdominal pain, and sometimes they complain of vomiting spells that are actually due to their migraine. This is a very important type and a very interesting type of migraine as well, in which a person can have a hemiplegia, and you might do a complete workup for stroke. For example, they have a headache, and before that, in the aura phase, they have a transient weakness of the right half of the body. So we might confuse it with TIA, and sometimes these continue, interestingly, for days and sometimes even weeks, and it becomes very difficult unless we get imaging to find out if it is due to the migraine or not. And you'll manage them unless you have a positive family history, just as stroke, but these go away and the patient becomes completely normal. And this happened many a time in their lives. So hemiplegic migraine is an interesting type. Retinal migraine, ophthalmoplegic migraine. Retinal migraine, you can have strong visual symptoms. In ophthalmoplegic migraine, the movement of the eye is affected. This vestibular migraine is more common than we sometimes think. Many people come into the clinic with the history of vertigo that lasts for minutes to hours, that has been present for many years, and it is also associated with headaches, or some spells are associated with headaches, and there's family history of headache as well. And you control the migraine, you control the headache, and the vertigo and the dizziness, they go away. Chronic migraine means a migraine more than 15 days a month, and a probable migraine does not fit the criteria. If you guys want to learn and screenshot anything from this presentation, this is the slide that I would advise you guys to remember. And this is the basis of your diagnosis and your understanding of migraine. Let me just check if everything is going fine. Okay, so whenever someone comes to you and you want to make a direct diagnosis of whether the person fits into a migraine and the diagnostic criteria, you ask them if they have had 5 or more attacks, in their life. So basically, first one is most important, 5 or more attacks. The headache usually lasts 4 to 72 hours. Patient usually says that I try to go to sleep, I try to lie on the bed, and that it gets better in the morning. Sometime it does, or otherwise it lasts 2 or 3 days and the headache doesn't go away. But I find it very important. And if the headache is less than 4 hours, unless it is treated by any medication, it is a red flag, and it means that you might be having any other type of headache because of the primary headaches or secondary headaches as well. And if the headache always goes on many hours, above 72 hours, then it is a red flag as well. Now, there are 2 characteristics out of 4 that you have the headache needs to have. One is unilateral location, means it is half headed. It can be left, it can be right, sides can switch, can be on the same side as well. But it also means, because you need 2 out of 4 characteristics, it is not necessary that migraine headaches would be present in half head. It can be present in the complete head as well. Otherwise, a very important part is that the quality of headache, whether it is pulsating quality or not. Usually patients come to say it is like a heartbeat inside my head, or there is something that is going in and out of my temple. So you need one of that. One of the differentiating points of migraine with other headaches is that its intensity is usually moderate to severe. So sometimes we ask them, what do you think is the visual analog scale, or simply 1 to 10 rating of your headache? And usually the patients who come with migraine say 7, 8, 9, or 10. Whereas people with tension type headaches or other headache disorders can sometimes come in the 0 to 6 category, or 5. I'm just giving it as an example. These are not fixed numbers, but however, it is very important pointers. Otherwise, aggravation by usual routine physical I just found out really late that you guys were not with me. I'm sorry about that. If it happens, then one of you can give me a small call, because I cannot while sharing, find out if I lose you guys. Okay, we'll speed it up. Don't worry. Again, we were at this very point, moderate to severe intensity.
Yeah. और मैं जा रहा हूँ, मैं नहीं पीता पीता शेक. No, no. मैंने पीना ही नहीं है, ना मैं पीता. Seriously.
Okay. Dr. Bilal is not going to drink a milkshake. Okay. So we were here. You guys are shy. Okay. Yeah. Yeah, so we were here. Okay, so then again, this is what you need to learn, and this basically helps you make diagnosis of many people without aura and unofficially with aura as well. किसी बंदे को जरूरी नहीं है कि पूरे सर के अंदर सर दर्द हो to have a diagnosis of आधे सर में हो to have a diagnosis of migraine. So either a unilateral location, pulsating quality, moderate to severe intensity, aggravation by causing activity. Migraine is disabling, and they are affected by the headache. When they have the headache, they cannot do their routine work. So you can have any two of these. Either the headache can be half-headed headache, and they are able to do their jobs, but they have a severe headache. Then you make a diagnosis. Also, there are associated features of migraine, including nausea and or vomiting. It means one of or either of these two. So if somebody is having dil kharab ho raha hai and ulti aa rahi hai with their headache, then you make the diagnosis that they are probably having migraine, as the criteria is fulfilled. If they're not, then you need to find out if they have photophobia and phonophobia. I cannot see into the light, and I want to turn off the light when there is headache, and no, I want nobody to talk to me when I have a headache, not even my kids and not even my family. And there not should not be another ICHT3 diagnosis at the same time. Migraine with aura, basically you need to have aura that lasts 5 to 60 minutes. What kind of aura? Visual aura, sensory aura. You might have difficulties in speech, motor deficits like we discussed in hemiplegic migraine. You might have brainstem features, including scanning speech that develops, including vertigo that develops at that time, or severe dizziness and paresthesia, again, retinal aura that might involve vision that is lost, one half of vision, or complete visual loss or blurring of vision. So you unofficially again can apply this very diagnostic criteria to find many, if not all, of the cases of migraine, and then apply this if you have aura. So are we following this? Any question that anyone might have till now? Let's continue. Taking the history is most important. You need to find out if it is migraine. You need to establish the type of migraine. It is with aura or without aura, any the type of migraine. You must rule out other primary headaches, including cluster headache, tension type headache, and if you can, to find out suna. This is something that I want you guys to focus very much on. And Dr. Raza asked before the presentation, what is the threshold for imaging in these patients? So you remember this particular mnemonic. It is a very good mnemonic that I particularly use in all patients who come to me with migraine. How do you find out that it is migraine? If somebody has a complete diagnosis of migraine by criteria, it is not 100% certain. It cannot be due to a secondary cause. So you use this a mnemonic to find out, and it goes by S is for systemic signs including fever and including weight loss. If these are positive, chance of secondary headache is possible. And N is for neurological signs. If there is fixed neurological signs and upgoing plantar or weakness or any other signs. If the onset is rapid, if it is thunderclap, then raises obviously the chance of secondary headaches, including subarachnoid hemorrhage and RCBS. If it is due to an older age, if someone comes with headache and you think it is even migraine, if it is in a person with 55 plus or a 60 plus age, that is not the age in which you are diagnosing migraines, because it is a disease of the younger population. For that population, you will consider secondary causes first, including giant cell arteritis, temporal cell arteritis, or other ischemic or hemorrhagic causes as well, or tumors as well. So the imaging becomes really, really vital in these people, especially these older patients. If the headache is positional in its characteristic, the patient says that when I lie down, the headache starts to increase, then it might be something with a raised ICP, including pseudotumor cerebri. If the patient sits up and has headache, that is worse. In Pakistan, basically, person usually says कि जब मैं सजदा करने जाता हूँ या जब मैं सुबह उठता हूँ तो मेरी सर दर्द ज्यादा होती है, signals chance of raised ICP. या जब मैं उठता हूँ तो मेरी हेडेक कम होती है, decreased intracranial pressure like intracranial hypotension. If it is associated with pregnancy or purpurium, then the chance of having a secondary headache is high. If there is prior history of any malignancy or prior history of any systemic disorder such as vasculitis, then you consider that secondary causes are high if the headache is precipitated by Valsalva maneuver. And this is a very good question if you can ask to find out if the patient is having secondary headache or not. You ask them, does your headache increase when you sneeze or when you cough? Things that raise the ICP, and even sometimes people with decreased ICP can also have worsening with sneezing, coughing, going to the washroom, squatting, and performing a Valsalva maneuver. I find it very important. Sometimes by using this mnemonic, Snoop 4, you can find out many a tumor and many a secondary cause that might be the cause of headache. And let me share you that many a times the diagnosis is confirmed by the criteria that it is migraine, but the headache is not going away, and you are suddenly forced to do imaging, and then it comes out to be something else completely. But if you do the proper evaluation first and foremost, then the chances of that happening is really less. Neurological examination can obviously help you to find out if there is any localizing sign. Fundoscopy, no examination of headache is complete without fundoscopy. And this is an art which we have forgotten for so many years. It is a very easily mastered and learned art, and patients love it when you do the fundoscopy. They see doctor took care and did something that was a little bit different and did not, some doctors, others did not do it. So you can pick many things, including optic atrophy, including raised intracranial pressure, and hemorrhages as well, retinal hemorrhages sometimes in patients when you do fundoscopy. This is how it was done in the past, and now you can do it like this as well. But they're really, really good fundoscopes, direct fundoscopes, pan optics that are available to our doctors right now. So this is something that you must be always wary of. This is papilledema. This signifies raised ICP, and this causes you to image and admit the patient and do something right now. So yes, Snoop 4. Any questions right now? Is it clear? Now we come to the some of the investigations. So primarily, it is a clinical diagnosis. You must be thorough and rule out other conditions that might be needed. Imaging, if needed, either get a CT brain plane or an MRI, prefer an MRI if you can. Baselines, if indicated, ESR, CRP, especially if you are considering temporal arteritis, somebody 50 plus who comes and then you need to give steroids. EEG is very rarely needed, if ever. So these were the 4 phases of a migraine headache. Now we're coming towards the treatment and the principles of treatment. So this is how it was seen a few years before, that a prodromal phase happens before the aura starts or before the headache starts, in which there are some problems concentrating, some irritability, and some fatigue, sensitivity to light, and some people report increased urination and muscle stiffness. The aura can last between 5 to 60 minutes. Headache, we mentioned, lasts 4 to 72 hours, and then post-drome, after the headache ends. Now there is an interictal phase that is increasingly recognized, that people who have headaches and then the headache resolves, between one headache and the other headache, they are having some symptoms that are different as well. So managing their headaches becomes really, really important in improving their general life. And you can do that by using 2 basic types of treatments: pharmacological, acute treatment, and prophylactic treatment. And basically, acute treatments are the treatments which aim to abort the attack and return the patient to a headache-free state. It is very important that they are not taken in the aura phase, and you give the acute treatments SOS. जब आपको सर दर्द शुरू होगी, you take this medication. It should be taken earlier in the attack. We went through that. There is basically the trigeminal system that is being activated, after which the headache goes into the head and spreads around the head. So if you can treat the headache when it is in the trigeminal distribution and not spread into the head by a cortical spreading depression, that is the best phase, because entering medication into the brain is quite difficult. So usually we recommend that you take the medication 5 to 15 to 30 minutes during the start of the headache, and the medication responds better. If one medication does not work, you can try another. A combination of NSAIDs and triptans is generally effective and recommended. This is basically the baseline and the standard treatment being given nowadays. And a standard treatment might include naproxen and zolmitriptan or sumatriptan, given at the same time at the start of headache. It is to remember that it is individualized. You can give NSAIDs only, you can give paracetamol, you can give Disprine, among other medications. And if these do not work, there are other agents as well, including ergotamine therapy and some new therapies, which we should see later on as well. They should not be overused. They bring relief and comfort to the patients. The patient should not tolerate these headaches to the extent of their severity. Now, these are some of the guidelines for acute management. These are some of the very highly effective therapies, and you can see that these include the triptans, these include aspirin, 500 mg, it's very important, include the NSAIDs, and including do goliyan paracetamol, and we do not have dihydroergotamine nasal spray in Pakistan, but we do have triptan nasal sprays as well, excuse me. So these are the medications that you must try and give earlier on into the headache to resolve this. Nowadays, there are recent advances, including lasmiditan. It is a serotonergic drug, and obrogipant. It is a CGRP mechanism drug that has come into the market, and these can treat patients, especially some my neurology fellows and friends. If the headache is not responding to NSAIDs and triptans, then you can give these drugs, and these have more than 50% response in the non-responders. So these are making their way into Pakistan as well. If you are having more than 3 headaches a month, or the headaches are not responsive to medications, or you want that the headaches decrease, the patient wants the headache doesn't happen, there's a nature and severity of the headache attached, so that the patient wants that it does not happen, you start a prophylactic treatment. It is supposed to reduce the number of headaches 50% or more. So very important, the patient comes to you with 7 headaches a month, and then you start a prophylactic treatment. They come back to you and said, it did not work. I am still having 2 headaches a month, but this is more than 50% or less. So you tell the patient, this is pretty much what we aimed for, to reduce your number of headaches. It might reduce to 0, it might reduce to 1, 2, 3, but your treatment is effective. You give 3 months, 2 months, 4 months trial and see completely how much the patient benefits. There are lots of options. Some are repurposed. Some recently came out which are migraine specific. Very important to use the medication side effects and the effects to the benefit of the patient. So that's such as if a person is having depression, it is very important to know that SNRIs, including venlafaxine and tricyclic antidepressants, might be the best option. If person has having lack of sleep, then obviously TCA is a good option in that patient. If the patient is having mood problems and very aggressive or bipolar or is epileptic as well, so divalproic sodium is a good option. If a patient is having obesity, you might consider topiramate. So what suits the patient? If the patient is very anxious, maybe beta blockers. So these are some of the drugs that you can give to decrease the number of headaches. Also very important, the flunarizine is one of the drugs that is used in Europe and Pakistan. It is one of the well-tolerated medications that you can use to reduce the number of headache. Now CGRP drugs are coming, which can be given to people. They're migraine specific who do not respond to these medications, and galcanezumab has come in Pakistan as well. It's expensive, but people who do not respond to other medications might respond to this or to Botox, and Botox therapy helps improve headache as well. There are some herbal and nutritional supplements which you should know. Magnesium in doses 500 milligram to 1 gram per day can help, especially in pregnancy. Coenzyme Q10, melatonin, and feverfew are some of the drugs that help. CGRP, Dania is asking, it is calcitonin related gene receptor. Calcitonin receptor gene peptide. So CGRP stands for that. These are the doses by which these drugs can be used, and you use them for their benefits and their side effects as well. The herbal and nutritional supplements, like we just mentioned. It's really important that you give the patient good counseling and good advice about the temporal profile of the disease, what you are expecting is going to happen when they start the medication. Ask them to make the decisions and make informed and educated decisions to get rid of their headache. Let them choose the medication and give them options. Must avoid medication overuse headache. It is seen that many people like to take pain medication, including paracetamol or NSAIDs or triptans, whenever there is headache. But you must always remember, if they take it more than 10 to 15 days a month, then this might become the problem in itself. So you must teach your patients that you will take your headache medication, abortive medication, maximum 8 to 10 times a month and not more than that. If your headache is more than 10 times a month, then we need to change the prophylactic medication or step up the prophylactic medication or start it in the first place. So you must avoid medication overuse headache. And many a times when the patient come to your clinic and they are having unremitting migraines, this is a main cause. You must tell them taking early therapy helps. You must offer them alternatives, and you must give and offer reassurance of and support. Patients usually complain that the doctor actually listened to their headaches and their problems, but did not listen to their complete problems. And in this case, it is even more important, as most of the drugs are repurposed drugs that are being used in other problems. So you must make a complete picture of the patient and give them drugs that are best for their particular circumstances, and listen to them completely, their concerns and their issues that might be having. There's some lifestyle modifications that help in reducing the number of headaches, and the most important one has been seen to be keeping good hydration and increasing regularity in life. It has been seen that people who sleep excessively on weekends end up having headaches. People who sleep less during the weekdays, same people have headaches. So if they sleep in a regular pattern or eat in a regular pattern, drink tea and coffee modestly, have good exercise 20 to 30 minutes 5 times a week, then the headache number decrease. Some dietary modifications need to be made. People who do not like cheese and it basically reacts poorly and causes them and triggers their migraine. Cheese, fried food, lots of coffee can cause it, almonds, and so many other things. So you ask the patient to keep a headache diary and find out what caused their headache in the first place. Wearing sunglasses and protecting them from cold and direct heat also helps reducing headache. It is very important to know what migraine is not. It is not if it is fitting at the primary headache. It is not if you're hitting the SNOOP4 mnemonic. If it is in older age, there's structural causes. If it is not responding to medication, it can be something else. If it is atypical, then it might be something else. If it has become chronic, more than 14 days a month, you need to manage it differently. Sometimes it might be migraine that is mixed with tension type headache, and otherwise it is medication overuse headache, and it's very common in Pakistan. So in all these conditions, you need a consult or you need to manage them a little bit differently, and then it comes up with the best decision. So it is treatable, it is preventable, it is manageable, and there are a lot of options for migraine. And I hope this presentation, although I'm sorry that the middle part became affected due to the lack of internet, and I hope that you guys learned a little bit of some of strategies that can help you manage migraines. If there are any questions or any comments right now, you can type them in the chat box, or you can unmute yourself and we can, address them. Yeah, I'm thankful. Okay, Dr. Raza asked TIA versus hemiplegic migraine, especially when presenting emergency setting, apart from duration. Well, sometimes, as you know, hemiplegic migraine is has a familiar predisposition as well. If there's a strong history in the person of having many such episodes previously, then you might think of hemiplegic migraine. However, you may need to do an MRI of the patient. Again, this is saying when a patient is highly suspected of having a hemiplegic migraine. Otherwise, you manage it completely like a stroke. It comes first time in your emergency, you manage it like a stroke. You can give TPA to the patient and it will not cause any harm. And I'm saying this with full authority and with literature that supports this. So if you're not sure, you manage it as a stroke, you can give TPA and proceed everywhere. But if you're strongly suspecting, then the DWI and ADC images can help you if you can do an early MRI. So TIA, obviously, you can't rely on TIA in emergency circumstances. It's either a stroke or a hemiplegic migraine. If it has gone away, then obviously, if it is TIA, then you look for the risk factors, and then you take both along during your workup. Yes. In ICD, 5 attacks. It's not 5 attacks in a month. It is 5 attacks total that need to have happened before you can label a person confirmed as having migraine. Remember, obviously, it can be the first attack of someone having migraine, but it is just that in research purposes and in clinical diagnosis, you need to keep your eyes open. For example, if a patient comes to me or you who has had 10 such episodes for the last 5 or 6 years, we are relatively more confirmed that there is nothing sinister going on if everything else fits. If the person is having the headache for the first time or the second time, then it is itself a red flag that you need to investigate what is going on. It might be the first attack of migraine, but you will deal with that a little bit differently and need more headaches to be very much confirmed and need some investigation if you can snoop for other causes. So I hope that makes it clear. It is for research purposes and it is for making the final diagnosis as well. Dr. South says, thanks for the session. Anyone else? I am thankful, Dr. Hashir, for your kind comments. And again, the 5 or 10 minutes that the internet connection went off was when the, I basically kept going on for like 5 to 6 minutes, but then I found out that you guys went there. Anyone else having any question, anything at all related to this topic or anything related to it? And then we can end the session later, or any comment for that matter. So thank you. I think that's that. And I thank you guys for bearing with us. We will have an in-person session in which I will like the guys from neurology community to participate as well. We will try to arrange something with you guys speaking as well. So I hope you guys are ready for that. It will take place in a couple of weeks' time. So till then, take care and enjoy neurology. Thank you.